Okay, I'm going to get started. People will probably come in as we go, but that's okay. You shouldn't be penalized for being on time. I'm Michael Pasha-Orlo. I'm a general internist, and I'm also the vice chair for the Department of Medicine for Research at Tufts Medical Center and Tufts University School of Medicine. I'm very happy that trust is a focus of a focus of interest here today, and it's just so important. I've been interested in trust as for quite a while, but really, and the intersection with health literacy, um, but really that's just loomed so large in this last couple of years. Um, you know, the topic's been super important for a long time, but never more than these last 3 years. Um, Advancing slides. There you go. So really the pandemic just exploded this topic in importance. The global pandemic just showed a really stark light on how big a problem we have in public health and in healthcare around trust and the role that health literacy can have in that. When you think about the pandemic, it's fair to also think of that it was really an infodemic as well. We basically turned a fire hose of information onto people, and then somehow we're caught blindsided by the fact that people struggled with that. Um, it got much worse than that I had anticipated. I knew there would be misinformation. I didn't know there were going to be actual bad actors, actual people seeking to promote disinformation. And in fact, it's just no question at all. It's always been the case that that this kind of a thing would lead to bad health outcomes. But in the infodemic and the pandemic and the global pandemic, this phenomenon did lead to people dying. No question about it. I spent a fair amount of time in the hospital at Boston Medical Center during the first phase of the pandemic, and it was really astonishing. One day, for example, we had a guy who I really thought was going to make it, and didn't make it. And I was in the hallway after his code, and after he had passed away, and I was talking with one of the residents, and she was pretty upset about the whole thing because we did think he was going to make it. So I said, hey, let's go for a cup of coffee. Let's leave the hospital, take a break. We're going to take a walk and go for a cup of coffee. So we left the hospital, walked across the street, and we went into a place, and it was a time in Boston where everybody was wearing masks, everybody. But there was a guy in the shop who was not wearing a mask, and he was talking very loudly in some unpleasant tones. And when I went up to get my coffee, he turned towards me, and he was wearing the following shirt: "The deadliest virus in America is the media." This was the shirt he was wearing. And I lost it. I completely lost it. And the resident actually pulled me out of the coffee shop, and then we took a walk, and I had to cool off. But approaching these topics with that kind of emotion isn't helpful. It took me a long time to get to that, but we're going to talk about this over the course of this talk. But there's just been a tremendous amount of misinformation, and this undermines trust, and there's been a massive undermining of trust, and it's led to death. So the first thing I'm going to do, I'm going to try to lay out the intersection in the literature of health literacy and trust across 4 different domains of trust. And some of the literature is very strong on, and some of it's not so strong on, and I'll explain. But trust you can think of having different types of domains. One is how people interact with information that they seek. And in that domain, information is like critical appraisal skills. This is like core health literacy stuff. How to do that is, and how to promote people's capacity with critical appraisals, core health literacy stuff. And that's like super important. Anyone who thinks that that they can avoid this topic has their head in the sand, because everybody is online all the time, and there's this fire hose there, and in figuring out what is core core health literacy trust intersection. Another domain is about interpersonal, how people talk with each other and all that. Another is at the organizational level, and then even at a societal level. So with respect to information appraisal, there's been a fair amount written in this space, but it's pretty clear that people with higher health literacy are much more likely to use medical websites, much less likely to use social media, blogs, several web pages. And if you control for demographics and all this, there's just no question people with lower health literacy, are more likely to be getting their health information from Reddit and blogs where there's active promotion of disinformation as well, or from pharmaceutical companies. It's just no question. There's like a lot written in this space, and that's been true also in specifically for COVID-related health literacy topics and many other topics as well. But if you think about interpersonal trust issues and health literacy, here the data, the literature is a little more mixed. You have projects like this one where they saw that there was a really strong relationship between having lower health literacy and distrust of physicians. At the same time, you have projects like this one, which showed like the reverse, where people with lower health literacy had higher trust in the physicians. And so it makes you kind of think of like, what are the cofactors here? Why would this type of disparate findings be observed across different types of studies? And there's a lot of other types of things. Here's another one where health literacy was strongly related with trust in the health system, after doing a fair job at adjusting for various characteristics. But here's another study, also well done. Friends of mine also did this one, where there was really no association between health literacy and trust. And so when you think about this kind of this part of the space, I think it's important to think about the cofactors in this. And there's some scenarios where people actually have higher health literacy, but they also have higher social capital and more power in general. And so maybe they're more critical. And so that what we're talking about in these projects about trust and health literacy may have to get broken down and further when you think about what does it mean and what's to be done. So when you think about at the organizational level, there's similar themes come up. So in this project, for example, they saw that people with low health literacy had lower trust. They found the healthcare system to just not be cooperative and not easy to use, and that was contributed to their sense of lower trust. At the same time, the people with the highest health literacy also had low trust. They just had much higher expectations about quality, and they just were dissatisfied with it, that the system wasn't working better than it was also. And it was the middle group that had the highest degree of trust. And this is the kind of mixed picture where you have to think of like, where's the social capital and how is it working and interacting, and in what ways for different phenotypes of people. And at the societal level, this is like, there's been just this massive degradation in trust and sources of trust. There's but here, the literature's also been mixed. And here's a couple of papers where health literacy was not a significant predictor, but this other one is actually a paper of mine where health literacy was a significant predictor of vaccine hesitance, vaccine confidence. And we have another paper coming out also about receipt of vaccine and receipt of boosters. Health literacy is a very significant factor there. Not only that, but actually that the racial and ethnic disparities in those variables are mediated by health literacy, which effectively means that in these cohorts, this is patients from Boston and Chicago, in these cohorts, that the racial disparities were really about health literacy. Actually, when you controlled for health literacy, there was no racial disparities anymore, and vaccine confidence and receipt of vaccination. Here's some more papers in the same space where health literacy was significant, and it's just this been a fairly consistent drum roll at the societal level. So, but as I've been saying, I think it's important to get a little deeper about this. And so there are these domains that I've been talking about, critical appraisal of information, interpersonal issues, or at the organizational level, at the societal level. And but at the same time, it makes sense to kind of go a little deeper about this construct. What is this construct about? I'm going to list a bunch of different things here. And these are things that different authors have focused on as components of trust um, in different kinds of studies, different types of contexts. And it shows you how the concept of trust actually really can mean different things and really should be may need to be broken down depending on what work you're doing. So for example, um, that the information that you're seeing is fair or accurate, um, or that the person that you're talking to is independent of other influences, or being transparent or honest, that you can trust that what's happening here is confidential. There's these different things that when someone's talking, that they're speaking authentically from their own voice, that they're reliable. There's so many things here that are these are like many of them have implications about what you would want to do about this topic. And it's happening all the time. It's so common. I'll give you an example. Reliability. Um, uh, Reliability is one of these things. I see it all the time. The clinicians go to the bedside of the patient in the morning, and they talk about whatever they talk about, and it's like blah 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 blah, and then they say, oh, but the test's not back yet, to know if you have cancer or not. I'll come back in the afternoon. We'll talk about that. And then they don't come back. So the patient may have zero comprehension of any fact, any medical concept that transpired in the blah, blah, blah in the morning, but they know if you're not reliable when you didn't come back to talk to them. And they could feel that. And so we're teaching people all the time about these aspects. But also, it also makes sense to think about the definition of health literacy in this context. And there has been evolution in this. So in the Healthy People 2020, the definition that many people are familiar with is the capacity to obtain, process, and understand basic health information and services needed to make appropriate decisions. But I've always been grumpy about the term appropriate in this context, because appropriateness actually is not trust. It's not about, appropriate to whom. That's not the goal here of health literacy. Appropriate is not the focus. The focus is to empower people, to inform people that they can make decisions that are consistent with their values and their wishes. And so, in fact, in Healthy People 2030, this has been changed, at least in the personal definition of Healthy People 2030 about health literacy. The word appropriate was expunged. I'm very happy about that. It took me about 10 years of advocacy, but it happened. And I think that this also, gets to issues of trust as well in this context. Let me back up also another whole other dimension about trust and the literature around trust that I think needs to be explicitly talked about. When you step back and look at the literature on trust, one of the main uses of this construct was as an explanatory paradigm for racial disparities. And effectively, if you just stand back and look at this literature, one of the things that was happening in these papers is the message is, you don't trust us. And this message really needs to be unpacked. It really needs to be thought through, because it has a lot of problems with it. For one thing, it's extremely othering. You don't trust us. And the concept is, oh, there's lower trust. African Americans have lower trust in healthcare, and and they have these differences. And then when you control for trust and these things, so that's part of why there's worse health outcomes, is that if you would only trust it, really that's a very othering perspective. And I'm gonna give a few slides. The next couple of slides are a little more about what I mean by that, and why I think that's an important thing to unpack and to deal with. But before going on to that, I want to point out something, which is the most common thing that happens in the discussion sections of such papers is some comment about Tuskegee. And I absolutely think it's important for people to learn about and understand the atrocity of just Tuskegee. We should not be hiding our eyes from that history. At the same time, in these papers, it's hard to not feel that one of the things that happens when you say there's this trust divide, Tuskegee, one of the things that happens there is that you're saying this was a problem far away and long ago, right? And that's not actually doing the work that we need to do to move forward on this topic. Let me explain more. Because in the healthcare system, there's a whole cycle of mistrust. You start by having bad experiences, then it's reinforced when you see disparities all around you, and you have your own direct experiences, and then that's reinforced when you experience discrimination, and then that's reinforced when the research is not transparent and open to the public, and then that's reinforced when participation in research is really disparate by groups, and then that's reinforced when the research results are not generalizable, and then the ways we try to step forward actually promulgate disparities. And so this is all happening in healthcare and healthcare research all the time. And so we have to unpack this. And this whole thing in health systems is itself a tiny little part of the story. People aren't coming to doctors or health providers in a vacuum. They're coming through the whole lens of society. This little thing is a tiny little part of it. It's in the context of a huge morass of really hard stuff that we frequently, don't actually contemplate or take on head on. Like we say we have a public health system. We came through this global pandemic, but in the end of the day, there were people who ordered their food through the internet and had it delivered to their house, and there were people who delivered the food. We have massive socioeconomic disparities, and people know, like if you're paid only when you show up and the pandemic happens, these things really played out very differently. For me, I was having quarantinis in the backyard. It was great, when I wasn't in the hospital. But for a lot of people, it was not like that. And it happens in all parts of this carceral system. 1 in 3 African-American men in the United States will experience imprisonment. It's overwhelming. We do this more than any other country in the world. And we think people should come into the health system with trust. That's in comparison to 1 in 17 white men. There's just so many examples like this in the education system. When it comes down to it, many people don't realize it, but about half of every dollar spent in grade school and in high school, about half of every dollar for every seat in that school is paid for by local property taxes. This just bakes into the system intergenerational disparities for wealth and inequality. And it's just so many examples of this. And and we think people are going to come into these interactions and say, yeah, I trust you. So there's all kinds of intergenerational educational mobility by race. It's very disturbing to look at these numbers, because or in the banking system, who gets a loan and how. So all these things, people do not come into our interactions in healthcare from a vacuum. They don't. So what kind of trust are we even talking about? What's the right level of trust? It's contextual, and it's going to depend on the influence of many factors. This is one way that I have come to think about it. The spectrum. There are going to be people who have so much distrust that they're blinded by their mistrust. There are going to be people who are so blinded by their trust. Neither of those are the right places to be. And actually the truth, like the balanced perspective, it will depend on the context. It will depend on the need at hand, the information that you have to deal with, the people that you have to deal with, the systems you have to deal with, the organizations you have to deal with. So, the person with blind mistrust, I've had patients come and say, no, you're not going to put Bill Gates's microchips in my arm. right? But I've also had patients who say, "Oh, whatever you say, doc, the doctor's always right." And, you know, probably a reasonable balance is in the middle somewhere. People should not be asked to remove their critique of society. You see someone not washing their hands, and you should be able to say, I'd like you to wash your hands." You know, people can't be so disempowered that their blind trust is actually putting them at risk. And this happens, both of those would be an error. And so when we talk about trust and truth, and it's actually uh, it has to be someplace in the middle. And the way to manage that is going to be advanced by health literacy. Um, and we'll talk about that a little bit. So ultimately, um, I think it's time to switch the script. I think we should stop talking so much about patient trust. Stop it. It's the wrong story. It's very othering. It points the finger at them. We have to turn around and think about ourselves. And what does it look like for us to be worthy of trust? What does trustworthiness look like? Health literacy can help us do that. Shifting to trustworthiness includes all the things I talked about before, that we're going to be fair and accurate, independent, transparent, honest, confidential, authentic, reliable, devoted to people, and caring, listening to people, empathic, attentive, not rushed, and not judgmental. Our judgmental thinking actually is not trustworthy. I've had too many experiences where my judgment was just leaking through in the way I talked with people about, say, vaccination. Not helpful and not trustworthy. Here's some examples of ways we can advance trust through a health literacy lens. Instead of saying patients need critical appraisal skills, of course they do, and we should empower them with them. But instead, we actually should simplify the materials. Like why focus? I mean, we have to. We don't have control over the whole internet. We should empower people with appraisal skills, but we also should simplify our materials. It would be completely not reflective of us to slow down on that effort. We could say, oh, when communication is hard to understand, the patients need to have more trust. Or we should say, when we talk in jargon, we're less trustworthy. We could say, well, when faced with organizational complexity, patients need to be empowered with more navigational skills. Or we can actually advance organizational health literacy and simplify things across the board. Some more examples. Small print is never trustworthy. It's not. Assuming comprehension, never trustworthy. Being defensive about people's sources of information is not trustworthy. Someone comes in and tells you that they looked something up on the internet. The most common thing for the clinicians is to get defensive. I mean, I have audio tapes of these types of interactions, and the most common thing is the providers are like, oh, don't look at that. I recommend changing your perspective about this. The person has just told you that they had motivation to learn about health. Run with that. Go with that. That's a good thing. Help them to get to information that you feel is balanced, is reasonable. But it's not going to be by poo-pooing them or by saying that they did a bad thing. Patient-centered care is risk management. Small print is it feels very lawyerly. It feels like you're trying to hide something. And clear health communication is patient-centered clear health communication is just much more trustworthy. Spending time with people to confirm their comprehension has to be done in a way that doesn't feel very testy, like you're testing people in a negative way, but it can be done, and it can be done in a way that actually promotes trust, because you're showing the person that you care, that they're empowered. You care that they have the tools they need to make the decisions they want. You care that they are going to get it right. And helping them find information that they can, patients have said to me things like, You know, in the middle of the pandemic, at that point, I was doing like, I think I was involved with 6 different clinical trials for different drugs about COVID and vaccination trials as well. And I was talking to a guy about getting a vaccine, and he said, "Yeah, thank you, Doc. You know, I know you're well-meaning, but I'm going to have to do my own research." And I'm like, "What does this guy even mean? What research is he talking about? Like, I'm doing like all these studies, but the thing is, like, that judgmental attitude from me is not helping anything." We did a series of projects to try to help the providers, help me and help the providers get past that judgmental stuff. And it was extremely powerful. We created a group of 60 African Americans in Boston who had said no to vaccination. There were 4 health providers. I had the honor to be part of this, and we had a series of meetings over time. And almost all the focus of this was about experiences of racism in healthcare. And it was extremely useful for me. It burned the judgmental stuff out of me. It was very, very helpful, and it changed the way I talk to people. So we're going to have to build the trust. It's going to take time. It's going to take effort. This is something that we have to earn. There are simple things like actually being reliable, actually doing what we say we're going to do. If you say you're going to talk to somebody in the afternoon and you don't go there, you know, that's not earning it. And if you know, and pursuing health literacy principles, I think is going to be part of the way of how we build it. If we don't, it looks like we're trying to hiding the truth, not trustworthy. So I'm going to stop there, I think, and see if we have any questions. Okay, I don't have any questions.
Michael,
Yeah.
can you talk a little bit, or will you be talking a little bit about what happens when trust is broken and how to regain trust from a provider perspective?
Yeah, it's very hard to do that, to regain trust. So I'll give you an example of a very common phenomenon that happens. In most hospitals in the United States, they have palliative care doctors, palliative care team. And when you think about what they do when they come there, you know, they're there to help relieve suffering, like to help people with pain. But the vast majority, like in most places, the majority of the consults that they do is actually communication because trust has broken down. So the majority of the palliative care consults that happen are about advanced care planning and not about pain, not about breathing problems, but just about planning for the future because the person is very sick. And they're called because there has been a miscommunication to the point that there's been such a breakdown of trust that they need an outside consultant to help them and maybe even help them repair their relationship. Sometimes that can work, but sometimes it doesn't work. And if you look at the literature around palliative care consults and what they do and where there are massive disparities, you know, like if you go through your life saying, I'm here to protect my mom so she gets the care that she deserves, and we haven't been able to afford the medicine because you ordered stuff for us that we can't afford, and we can't get this test because of this and that, you know, the insurance company that. And now all the way at the end of life, the people come in we don't even know who they are really, but they don't really know who we are. And now they say, do you want to take her off the respirator? Like, where were you for the last 40 years when I had to struggle for every single thing? Okay. And a lot of doctors go into those conversations without appropriate humility about what what's happening there with family members, and then when they see that things are going badly, they pull the ripcord and they bring in the palliative care doctors who
Yeah,
usually
so I
who
think those are really good points, especially, end of care and family involving the family members, and understanding some of the cultural differences. I've experienced, a very
oh there's
traumatic process in that too. So that
yeah.
would be a really another topic.
Well, there's an excellent point in the chat. Also, chaplains, absolutely. Yeah, okay,
Yeah.
yeah, chaplains too. And I completely agree. There's no reason to have not mentioned them. And um, there's a and I've done a lot of work in the space of end of life decision making. There's massive health literacy phenomenon there, and in actually in most of our projects. What people have purported to say were race or ethnically connected differences for preferences or anything, actually were all mediated by health literacy. I have several papers in that space, and it's appropriate. It's super important to differentiate. If I say uh, there are cultural differences, then the primary mode of thinking about this when you go and engage with that is cultural competence, cultural humility, protecting and upholding people's values. But if I say that their health literacy agenda, then you're there for education and empowerment, and you have to do both. You
Yeah.
have to be able to do both. And you can't just say, "Oh, this person looks like this, so I'm done my educational agenda." No, you have to do both. Okay, so uh, um,
You
I
have some chats and you have some questions in the Q&A. Do you want me to read them, or would you like to read them and address them? And then you have 10 minutes left.
okay. Um, so I think these things can be addressed very well in medical school, but it's super important to figure out how to do this in medical school. Ultimately, it cannot be done without a tremendous amount of professional development among the faculty. And the reason why I say this is that this is the kind of topic where the hidden curriculum will ruin the overt curriculum. So you can have sessions where even you have like practice these things, and you can have sessions where you teach about teach back and all this kind of stuff. But the hidden curriculum is that when they go onto the wards or they go into the clinic and see doctors not doing these things, then you're ruined. You're ruined. It's just
Yeah.
completely ruined. So these topics actually should not be thought of as adding a course to a curriculum, because that doesn't actually change the culture of all the care environments where then the hidden curriculum actually exerts its power. And so it's like it's great to have those classes, but when you have those classes, effectively you're speaking to the choir, and you're not converting anyone else.
Yeah.
And then when they go into the care environments, they see a different story, and then you're done. Look, it's important to speak to the choir. Maybe the choir can sustain the congregation, but it's not enough to change for the whole scale change that we need. Okay.
Do we have some questions? If you go onto the Q&A,
That was the first thing in the Q&A that I saw about
and
the
then
medical school. Next one. Yes. Yes. So I agree that in the end it's got to be a partnership, and I think that in the range of the literature, so much being written about trust, shifting towards what does it look like to be trustworthy is just so needed. Now, ultimately, in the end, it's a collaboration, and there are also things that are very specifically like skills people do at home. Most of healthcare is self-care. Most of health information is on your own at this point, on the internet, and so we have a proposal in for an approach to teach critical appraisal skills. It's called Be Critical. I don't know if it'll get funded yet. We'll see. But there are some interventions out there, mostly small studies about teaching critical appraisal skills. Let me just go down. Oh, being a chaplain, fantastic. About the chaplains for one moment. I have a fair amount of experience in this space. I have a lot of exposure to chaplaincy training programs and working in contexts where that's the case. And in most health environments that have chaplains, the chaplains are not well integrated into the teams. And if you look, even if they do write in the chart, which not always the case, but even if they do write in the chart, if you look to see who's even reading their notes, they're not well integrated into the teams. And so there's great opportunities to improve communication across the team and to include the chaplains in that conversation. We'll see if Aaron agrees with that. Yes, I agree with this this issue, the point about chaplaincy, about hospice and palliative care. Oh, we actually have a graduate of Tuskegee here. Fantastic. I hope I hit the notes well on that topic. I do really feel that people bring it up kind of and wave away and say, oh, that happened a long time ago, that was far away, like, why are you not trusting me? And I just think that's missing the mark. And you know, that's not to hide from this history. It really should be known, but to use it as a shield, that's just bizarre. And I think that's kind of how it sometimes gets used. I don't know, yeah. I don't know if I missed any points here in the chat.
If you go to the Q&A, there's a couple questions, and we have about 5 minutes left.
Oh, I was looking in the chat, not the Q&A. Sorry about that.
That's all right.
Okay.
The first one looks like it's, what is your opinion on vendor patient education products versus institution-made materials?
Okay. Well, I think in the end, what's most important is the quality of the materials, not who made them exactly. We actually have a brand new R01 funded by National Library of Medicine last week, so it's brand new, like just started, around the illustrations that are in patient education materials. And this started for me because I came to realize that there's like almost no empirical evidence at all about the images, in the medical images, the illustrations that are in patient education materials. And I had done some little work to show that most of the images are like completely not understood by patients, especially patients with low health literacy. And actually some of them were like anxiety provoking or felt to be inappropriate in various ways. And there's just a ton of issues to unpack. You know, since I've been looking at the empiric data that's at least been in the published literature around these materials, I would say there's just a ton of improvement that can be made across the board. This next project of ours is going to be focusing on the images that are in those materials. Hopefully I will have a lot more to say about this topic as we get to do the project. It really is just getting started. There's, I think one message that's fair to say is that almost anything that's outside of the lived experience of the patients is very hard for people to understand. There's just a ton of images that depict things that are not in the lived experience of patients. You know, if you can use can imagine like a picture of asthma and you can magically see inside the lungs and you can see the lungs inside the person's body, and then there's a little image that comes off the side and a magnification sphere over here and you can see some bronchioles and some alveoli. That means nothing to people who didn't take um, go to college. It means almost nothing. And for some people, it's these types of things are scary. And so um, instead of voting for, proprietary or non-proprietary patient education materials, I would say we just need to improve the quality generally. Um, so um, Oh, the rhetoric from politicians. It's
If you
been
could if you could address that without making a political statement, otherwise maybe we could just move on to the next question.
um, people in power really, it'd be great if they could have um, sensitivity about the impact of what they're doing, and I just had many experiences where um, things get repeated. It doesn't have to be politicians. It can be people with any kind of social power, social influence. And so this is true of many people who um, capture the attention of large groups of people. There's just a lot of ways that there can be um, untoward, unfortunate outcomes. How
That's
about
a good
that?
point. That's
Yeah,
great. That's
yeah.
great. Thank you. That's really something to consider.
So
And the
yeah. Any
last
other?
question, and then we have to end, but before we do that, I want to say thank you so much. Amazing presentation, amazing delivery, just a lot of information that's very useful.
Great, thank you so much. Send me emails if you have additional questions. It's unfortunate in some ways that we have to do this through a webinar, but of course, it meant that I was able to stay here in Boston, but which is what I needed to do. I had to be here today. But thank you for having me. And you know, there's so much work to do on this topic at the intersection of health literacy and trust. We need a tremendous amount of additional innovation to happen here. There's not one answer that's going to fix this problem. We need tons of hands on deck. And I just want to make one pitch, which is I work with IHA for our journal. I'm the editor of the journal called Health Literacy Research and Practice. If you're doing work in this space, health literacy generally, but especially health literacy and trust, I would love to read your manuscripts if you might send them our way. If you're unsure if your project is a good fit, send me an email. I'm happy to engage with you and to see how it could get to could get to be appropriate for the journal. And so don't be shy. I try not to be a nasty, mean editor. I try to be a helpful editor.
Thank you so much. Could you
Yeah,
put your email address in the chat? And
yeah,
will it be on your final slide deck that you submit?
yeah.
Okay, thank you.
The easiest email for me is mpo@tufts.edu.
Thank you very much. And there's some other questions there, people, if they want to, they can reach out to you through email. Our next presentation starts in 5 minutes. Don't leave the link that you've accessed for this presentation. The next presentation is from 11:45 to 12:30. Go grab yourself something to eat and be back in 5 minutes for building trust through conversations with our community. Anne got a little plug earlier, so thank you so much.